Hello, everybody, and welcome to the latest of the Leading Forward series. My name is Mike Trace, hope you know, and I'm the Chief Executive of Forward Trust, hence the name Leading Forward. This edition is going to be looking at the subject of consumption rooms, a health and care service that there's been much discussed in policy and practice circles, and is a discussion within us as the sort of drug and alcohol treatment and recovery profession. We've talked about consumption rooms for many years, although there isn't a very widespread implementation of them yet. And within this subject, I'm hopefully going to go through 4 issues in this edition. The first one is, what are consumption rooms? It's a name bandied around, and we ought to describe what we mean by that. Second of all, a short history of around the world of where consumption rooms have been implemented and what the findings have been so far. Thirdly, to have a look at what's happening in the UK, where this debate has gone and who's saying what and what do we know so far. And finally, have a little bit of a think about where this leaves Forward Trust as a service provider. Should we be involved in the consumption rooms movement and trying to implement principles along these lines? So, first of all, what are consumption rooms? This has become the sort of main name around the world used for these facilities. Other people call them injection centres, safe injection centres, overdose prevention centres. So there's a variety of names, but let's use the single noun consumption rooms. They basically describe facilities that are based on a single logic. And the logic is a harm reduction logic, to say that if there are going to be people out there injecting drugs or inhaling drugs in dangerous ways that might affect their health or their lives, then we should be creating centres where people can do that with the maximum possible safety and supervision. So consumption rooms generally are centres, facilities developed by health or social care authorities to say, if you're going to be using street drugs or even prescribed drugs, then you should be using them in the safest possible environments as an alternative to using alone or in hidden places where overdoses can turn into deaths very easily. So that's the basic logic behind consumption rooms. In practice, they are health facilities. The way the research and the debate has gone around consumption rooms is very much viewed them as health facilities. So they generally, where they have been implemented with a very clinical feel. They are health facilities with health equipment, staffed by nurses, staffed by healthcare staff, and are usually quite well-resourced facilities. So they have a lot of clinical equipment to help people to use safely, but also to react if problems happen. Most consumption rooms have acute health facilities that can intervene if an overdose happens. But also most consumption rooms have other elements in them. They can be linked to facilities where substitute drug prescribing goes on. So obviously if people come in who are using street drugs, the health staff will want to talk to them about safe supply and safe prescribing. And they also try to create settings where those who are willing to talk about their options can get psychosocial support, can get talking therapies and access to other forms of treatment. All of these elements are usually present in the consumption rooms that have been developed so far. So that's what consumption rooms are. Let's have a little talk about the history of them. First thing to say really is this idea of places where people gather together to use drugs so that there may be a supportive response if an overdose happens. That wasn't invented with consumption rooms. The idea of health facilities, official facilities doing that is about 20 or 30 years old. But even before that, I mean, you talk about opium dens, very informal consumption rooms. They were places where people gathered to look after each other if something went wrong. And I know, because I did a lot of homelessness street work in the 80s, there are places around London where I was working at the time that I would describe as pretty informal consumption rooms. They were places that it was known that people gathered together to use because that was safer than using on your own. Of course, they're not facility or officially sanctioned, but they were had a lot of the principles of what we now talk about consumption rooms. In terms of officially sanctioned facilities, the pioneers, I think, would fairly be say, were Vancouver in Canada and Australia in Sydney originally. And these places were the first to try officially structured, officially sanctioned consumption rooms developed as health facilities with staffing, with public funding. Although it's less known, those are kind of the celebrity consumption rooms. Around the same time, there were several European countries, particularly Switzerland, Germany, Netherlands, who were implemented similar facilities, but with much less attention, much less fanfare. So over the particularly the last 20 years, these sort of facilities have been developed to varying degrees in 12 to 15 countries and generally have had good results. I mean, the objective is to reduce the risk of death, to reduce the risk of infection, and to bring users out of the shadows and into services. And everywhere where consumption rooms have been implemented seriously, they broadly have met those objectives. Most of the research in the consumption rooms say, yeah, they do what they aim to achieve. They attract people who would otherwise not be in touch with services. They reduce the number of overdoses, and notably the number of overdoses that turn into deaths massively reduced. And there's still arguably no deaths have ever taken place in a properly sanctioned consumption room. So they've pretty much done what they say on the tin. They address the objective of reducing deaths, which most countries obviously do want to reduce drug-related deaths. But still, they are very slow development in the countries even that have sanctioned them. But also there's many other countries around the world where governments and local health authorities will not sanction them. So they're facilities that broadly prove themselves, but still not commonplace in most countries. So where does this policy resistance come from? And it's probably the same for many of you will recognize that back in the 1980s, we had exactly the same with needle exchanges, the idea that you gave out clean needles to protect injectors from contracting conditions such as HIV or hepatitis. Of course, by doing that, you're doing a harm reduction thing, and you're saying to some extent we condone or we allow and we tolerate the drug use. We don't try to stamp down on it, but we help people to keep themselves safe. And it's the same sensitivity now than it was in the 80s, is many political actors, many people in the sector as well, sort of say, well, you have to be really careful that you don't condone drug use or you don't enable it to happen. So it's that old sort of zero tolerance versus harm reduction argument. And I'm particularly surprised, I've been in the field 40 years, that we're having the same political debates now that we were having back in the 80s. And that definitely applies to consumption rooms. That's mainly the reason why a lot of governments, a lot of international organizations have not openly called for an effective public health measure that reduces deaths, because they are squeamish about the idea of being present, officials being present, nurses being present where people are using illegal drugs. But in my view, I'm very much a pragmatist. That this gap between policy and research evidence is really regrettable. It is pretty clear that while creating consumption room facilities is not a panacea, it doesn't mean to say that every death is prevented or every user totally complies with what you'd like them to be doing. But they do, in general, help to achieve what they set out to achieve. And as I say, it's therefore surprising that they're not more widespread implemented. Now, in the UK situation, this gap between policy knowledge and research evidence is particularly stark. The UK, all through the 80s, 90s, early 2000s, was probably a world leader in harm reduction in its research, its evidence, and pushing for good practice. But in the UK, we've been very much behind the curve on consumption rooms. They've been debated, I think, seriously for a good 20, 30 years. But the government position, even up until now, has been that they are against the development of consumption rooms, largely for the squeamishness I referred to earlier, is that when politicians look at it and say, well, we're going to have to sanction something that will tolerate illegal drug use, will be seen as supporting people to continue using drugs, then politicians tend to back off it and say, no, we're going to take the zero tolerance approach. And that is still the case now, has been the case when I was in government, has been the case through the 14 years of Conservative governments, and is still the case with the current Labour government. Despite the UK having the highest overdose death rate in Europe, there's one exception in the Baltic states. There are some small countries with similar death rates, but generally UK is the area that has the biggest problem with people dying early, dying young from drug overdoses. We still are not pursuing in any structured way one of the measures that could help reduce this death rate, which is, in my view, quite surprising. We were slightly hopeful when Labour came in last year. We had some good people in there who understand the health issues, but we did have a statement from Diana Johnson, who was then the drugs minister, who made it clear that while they were willing to allow Scotland, through its sort of delegated powers, to go ahead with a consumption room, they were not going to sanction it as a UK Home Office. And their reason for that was an interpretation of the Misuse of Drugs Act. It's a subjective interpretation, saying that there is a clause in the Misuse of Drugs Act that meant that if you allowed your premises to be used for the illegal use of drugs, then that would be contrary to the Act. If you read the Act, that refers specifically to the illegal use of opium and marijuana. So if you are a minister, you are choosing to use that clause of the Act subjectively to justify a position against consumption rooms. There is no basic fundamental legal reason why the Home Office has to take that position. So that's regrettable. That's how it is, though. That is the current government position. And as long as the government holds that position, it's going to take a very brave local authority, health authority, police chief to implement a consumption room in their area, because they're going to get attention from the Home Office. As I said, Glasgow is the exception. There was an agreement made a couple of years back where the government at the time, UK government, agreed to accept that the Scottish government had the delegated powers to say it would allow a consumption room, and the first one has been developed in Glasgow, and that has been running now for about 7 months. And so we do have a UK example, and it's the Glasgow one that I actually visited a couple of weeks ago. Early days, obviously, but it's the Glasgow is very much a health facility. It's based in a health clinic that also provides general help to the homeless population, general health care. It provides prescribing services, the usual sort of clinical drug and alcohol services that you and I will be very acquainted with. So it's in a big health centre in the centre of Glasgow. It's a well-known place, and it's very close to the drug dealing and sex work areas, so it seems perfectly well located. It's called the Thistle, very proud Scots, and it's run for, as I say, about 7 months now. They've got about 500 users signed up. You have to register to use the centre. They see about 40-odd people a day who come in and inject. And they've had over the 7 months of operation about 60 overdose incidents, clearly no deaths, and they've managed those incidents in the way you would expect a good health service to, which saves an awful lot of time and money to the ambulance services, the A&E. They manage the vast majority of those incidents on site, and everybody survives. So broadly, the Glasgow Centre is functioning as it said it would function. But obviously it's a hot political topic in Scotland. There are big fans of it. There are big critics of it, and they're all arguing over the evidence and the cost and whether the centre should continue or other ones should open. So what does all this mean for the Forward Trust? We are a community service provider, just the same as those Glasgow guys. We run community drug and alcohol services in Kent, in Medway, in Essex, and part of our job is to try and keep the rate of drug-related deaths down, the rate of drug overdoses down. And we do that by a whole range of outreach work and attempts to keep people safe, and naloxone projects, and some very creative work we're doing at the moment around suicide prevention and getting people into pathways into recovery. So we do all what a good drug and alcohol service should do, but we are not running facilities where we support and enable people to take their drugs. Now, that's not surprising because we'd be breaking the law, as the Home Office say, if we did open such facilities, same as any other place in any part of the country. The Home Office position states that any services running this way would be in contrary of the Misuse of Drugs Act, and the view of commissioners, the health budget holders, mean that we don't have, as a provider organisation, we don't have the ability to run one of these even if we wanted to. I go back to an early part of my career, I was thinking in the 90s, where a lot of these informal spaces where service providers blurred the boundaries and tolerated a certain amount of drug use on their premises. There was a really scary court case went through that a few people may remember, called the Winter Comfort case. It was a homelessness shelter in Cambridgeshire where the management did have and wrote down policies and protocols that enabled people to use safely within the building. They ended up in prison. The two managers of that service were prosecuted, and really shocking to people like me who were also managing services at the time. The local law enforcement proceeded with those prosecutions, took it all the way, and they were sentenced to prison. I'm not sure how long they actually served, but the Home Office has shown previously that it really means business with this Misuse of Drugs Act prosecution. So that has left me and many others with an impression that if you try and bend the rules, it'll probably end badly. The challenges, I think those are the regrettable things, those political game playing with something that could save lives. But there are real challenges around consumption rooms. I don't think it is as simple as some of the advocates as consumption rooms say. And I've always said, when I'm asked for my policy view on it, is you shouldn't view consumption rooms as a panacea. And I think there's two main reasons for that. One is that the job you're trying to do is find thousands of people living very chaotic lives and encourage them to basically make an appointment, come to a particular place to use their drugs and to use safely in a clinic setting. There's a whole host of people who will not comply with that, partly because they don't want to come to the setting. There's a particular problem in the Glasgow centre was talking about this, that women attend in the centres because the offer you're making to some of those women are come here, attend the centre, have a cup of coffee, go and use your drugs, come back and recover in the recovery room. But they are in the same centre as a lot of men who they've been abused by. So to actually be in the centre is actually a risk to them. So there's all sorts of practical barriers to achieving the perfect consumption room. The other problem is they're a bit expensive. As I say, because they're politically controversial, then the model of consumption room that certainly countries like the UK would only tolerate is a very highly specified, very high quality, very highly staffed health facility, and those don't come cheap. The Glasgow one costs more than £2 million a year, and so the cost-benefit argument is brutal, but the cost-benefit argument is a difficult one. If you imagine if you work in our East Kent services, for example, would we spend 2 million of our budget on a single facility? I'm not sure we would. So there's very real cost issues, cost problems there. And people do understandably focus on the political arguments, which I do find really depressing. The fact that a supposedly humane country like the UK is not politically comfortable with saving people's lives. Yeah, that's definitely all true, but I do think behind that there are some very practical and fiscal barriers behind the widespread development of consumption rooms. So where does that leave us with the Forward Trust? We do have, like every other service provider, a deep commitment to saving the lives, preserving the health of our clients. We do that in all sorts of different ways. We have a mortality review group that looks at the different things we can do to reduce death rates. As I say, we do a lot around naloxone, a lot around outreach, a lot around suicide prevention. These are great pieces of work. But I want us to keep being creative and groundbreaking as a service provider to try and always come up with new measures. And we should keep talking about consumption rooms, but I'm afraid until the Home Office changes its position, organisations like us are very limited in what we can do. Sorry to end on a downer, but look forward to further debates about this with colleagues and outside the organisation. Thank you for your attention.